Good afternoon, everyone. In the interest of time, I think we'll go ahead and get started as people trickle in. Certainly feel free to grab your lunch. If you haven't grabbed your lunch, feel free to go get lunch and then bring it back. Welcome to today's symposium entitled High Stakes, High Sensitivity, Troponin-driven Diagnosis in High-Risk Chest Pain. My name is Elizabeth Shouldice. I work full-time as an emergency physician at the Queensway Carleton Hospital in Ottawa. I'm also very proud to serve on the Canadian Association of Emergency Physicians Board of Directors, and I'm chair of our Public Affairs Committee. I'm delighted to be your moderator for this afternoon for what I know will be a very useful and very interesting session. Our symposium topic was independently conceived by the Conference Scientific Planning Committee, although we did receive some financial support from Abbott in the form of an educational grant. All efforts were made to mitigate any bias. So just to go through quickly our disclosures, I don't have any. And all material was reviewed by the Scientific Planning Committee. We do have several learning objectives this afternoon, which our speakers will go through. We're very lucky to have two very esteemed colleagues with us today to present on this topic. They are true experts in this field, so I encourage, if you have questions, to save them for the end, and we'll make sure that we have time for questions. They've also graciously agreed to be around after the presentation to give us more information on their topics or to respond to individual questions. So it's my pleasure to now introduce our distinguished speakers. First, Dr. Andrew McRae is an emergency physician and scientist based at the University of Calgary. He's published extensively on the use of high-sensitivity troponin for the diagnosis of myocardial infarction in the emergency department. He's contributed to the development and deployment of high-sensitivity troponin testing pathways in EDs across Canada. His current research focuses on improving the accuracy of diagnosis of myocardial infarction in patients with kidney dysfunction and in the development of more accurate risk prediction tools to identify patients with symptomatic coronary artery disease after MI has been ruled out in the ED. Thank you very much. We also have with us Dr. Adam Singer. Adam's main areas of research include cutaneous wound healing, burns, tissue adhesive, pain management, and cardiovascular disease. He has over 400 publications and is currently editor-in-chief of Clinical and Experimental Emergency Medicine. Dr. Singer has had multiple leadership positions and was past Secretary-Treasurer of the Society for Academic Emergency Medicine and as a member of multiple committees at ACEP and the AHA. Dr. Singer has won several national awards, including with the American College of Emergency Physicians Outstanding Contribution to Research Award and the Society for Academic Emergency Medicine Junior Investigator Award. Certainly two very impressive speakers, so I'll just sit here on the stage and listen to them as well. I would like to welcome Dr. McRae to start our talk off. Thanks very much.
All right. Thanks very much for the kind introduction, Dr. Shouldice. It's great to be here with people this afternoon. I'd like to get to know you folks a little bit better. So I just wanted to take a show of hands survey. How many people are using high-sensitivity troponin assays in their emergency departments right now? Okay, so most of you. Keep your hands up if you remember making the switch and there being growing pains or a bit of a learning curve to using high-sensitivity troponin assays. Okay, great. I'm glad you're here. Are there people in the audience who are still using conventional or older generation troponin assays in their shop? I suspect there might be if they're working in some rural or underserved areas or places that have very small point-of-care laboratories. I'm going to be talking about some keys to success in implementing high-sensitivity troponin testing at your site. So when you do make the switch, I hope what I talk about today is going to be relevant to you. I'm really lucky. I work in a place where we've been using high-sensitivity troponin assays for about 13 years now. And we've collectively developed a pretty good sense for how to get the most out of these tests to be able to make safe and fast disposition decisions. But if you look online, implementing high-sensitivity troponin testing has been a struggle in some places. Just a couple of days ago, I looked on some emergency medicine subreddits, and you can still see comments like, high-sensitivity troponins suck. Why am I such a bad doctor? I can't figure out how to use high-sensitivity troponins. So the struggle is real, and we only have 20 minutes. I think it's too much to expect to be able to present everything everybody needs to know about how to use high-sensitivity troponins, but I'm going to try to provide a high-level overview on how to use them successfully, how not to use them, and talk about some of the key ingredients for successfully implementing a high-sensitivity troponin testing program at your hospital. Most of all, the biggest point that I want to emphasize is that this is a sophisticated test, and I want you all to aspire to be sophisticated users, because it's only by being a sophisticated user of this test that you're going to be able to get the most out of it. A couple of formalities to get out of the way right off the bat. I do receive some research funding from the Canadian Institutes of Health Research and from Roche Diagnostics Canada, and I've received some honoraria for implementation work for high-sensitivity troponin testing in the province where I work, but don't have any other financial conflicts of interest. So if we're going to talk about how to use high-sensitivity troponins, we have to talk first about what they are and how they're different from previous generations of troponin assays. So high-sensitivity troponins have two defining characteristics. First, they can detect very low troponin concentrations. The textbook definition is that a high-sensitivity troponin assay can measure or quantify troponin in the plasma of 50% of normal healthy people. So assuming that everybody in this room is healthy, about half of us should have detectable and measurable troponin concentrations in our blood right now, just sitting here. Secondly, high-sensitivity troponin assays are really precise at low concentrations. So at the 99th percentile of normal, the cutoff concentration that we use to identify myocardial injury in the universal definition of MI, the coefficient of variation of the assay, or what we sometimes disparagingly call lab error, is less than 10%. So high-sensitivity troponin assays can reliably measure very low troponin concentrations, much lower than previous generations of troponin tests could. And that difference between the new troponins and the older troponins has huge clinical implications for how we use them. So let me try to translate that with a visual illustration. Many people, about half of us, have some small amount of detectable or measurable cardiac troponin in our blood. As we experience myocardial injury from whatever mechanism, maybe we've just finished running a marathon, those troponin levels might increase. And in the setting of a myocardial infarction, we see an exponential rise well above the 99th percentile concentration of a normal healthy population. Older generations of troponin assays could only reliably measure troponin concentration that were well above the 99th percentile. In other words, they could only detect troponin concentrations that were consistent with myocardial injury. And in that sense, they were awesome binary tests. If your patient had symptoms worrisome for symptomatic coronary disease and they had a measurable troponin concentration, then you made a diagnosis of MI. That patient needs admission and an angiogram. The trouble, though, is that they couldn't detect the small but potentially clinically important changes in troponin that we see early on in ischemia. So to achieve an acceptable sensitivity to ensure that you didn't actually miss an MI, you had to do a repeat troponin test 6 to 12 hours after the onset of symptoms to be confident that that patient didn't have biochemical evidence of an infarct. So working up a patient for chest pain took a long, long time. The new generation of high-sensitivity troponins are a different beast in that we can now measure even the low troponin concentrations that healthy people have, and importantly, we can see small, clinically important rises in troponin concentrations that we see after only a brief period of ischemia. And that means we have to use high-sensitivity troponin assays differently. They're not binary positive or negative tests like the older generation or assays. We still do an initial test when the patient arrives, and if the initial concentration is non-diagnostic, we can do a second test a very short period of time, just 1 to 3 hours after the first one is done. And what we're looking for is a clinically important change or delta in their troponin concentration that has a robust basis of evidence to have high sensitivity for ruling out MI or high specificity for ruling in MI. This approach has been formalized into guideline-endorsed diagnostic algorithms for ruling in and ruling out MI with high-sensitivity troponin. These were developed using statistical techniques to identify cutoff values and change values that accurately rule in or rule out MI. So if your patient presents more than 3 hours from the onset of their symptoms and their troponin concentration is undetectable, then you're done. You've ruled out an MI with a single troponin measurement. For those that you can't rule out with just one, then you do a repeat sample 1 to 3 hours after the first one is done. And if their troponin concentration stays low, if their delta is less than an evidence-based cutoff value, then you've safely ruled out MI for that patient. The sensitivity of these algorithms for ruling out MI is typically in the 98.5% to 99% range, so there's just not much room for improvement. They're about as good as you can get. The miss rate is vanishingly small, and you can safely rule out 2/3 of patients with this approach. On the other end of the spectrum, if a patient's troponin concentration is very high, or if you observe a much larger change, then you can confidently rule in MI with a specificity about 85 to 90%, so much better than the previous generation of troponin assays did, and much faster. And you'll rule in MI in about 10 to 15% of patients. You're going to be left with a handful of patients, about 15%, that you're not going to be able to rule in or rule out with 2 serial measurements. And you need to be careful with these folks, because the incidence of acute coronary syndrome in these patients is somewhere in the neighborhood of 10%. These are people who might have presented early, and so you just haven't seen that exponential takeoff in their troponin kinetics yet. They may be the patients who, in a bygone era, you would have called unstable angina, but they have now a small, measurable increase in their troponin concentration that is a result from myocardial ischemia, from symptomatic coronary disease. And then there's going to be the collection of patients who might have chronic troponin elevations from chronic heart failure, kidney disease, or other conditions, and they can be tough to tease apart diagnostically. So the most sensible next step for these people in the observational zone is to do a third troponin test, just to make sure that their troponin concentration isn't rising. And then if you still haven't ruled in or ruled out MI, you should consider using a structured risk stratification or risk prediction tool like Heart or EDAX to help guide your diagnostic decision making. The other thing to keep in mind that a number of these patients are going to have alternative diagnoses that we want to be aware of. So all of the other high-risk causes of chest pain and troponin elevation, like myocarditis, PE, dissection, the other ones that you need to keep your eyes open for. And so this is the people in the observational zone are a relatively high-risk group, and we need to take them seriously. Using these rapid diagnostic algorithms, you really need to know and get comfortable with the specific troponin assay that your hospital is using, because every assay has different numbers for ruling in or ruling out MI. This is a table from the online supplement to the 2023 ESC acute coronary syndromes guidelines. So if you go to the guidelines, then scroll all the way down to the bottom of the table of contents, there's an online supplement, click on that, that's where this table lives. It has the rule in, rule out, and delta values for 0 and 1 hour algorithms and 0 and 2 hour algorithms for all the commercially available troponin assays that were available at the time that the guidelines were published. And so you need to get to know the specific assay that you're using at your hospital, get comfortable with the numbers, and figure out some memory tricks to try to help you remember the numbers. So just for example, at my hospital, we use the 2 hour troponin T algorithm that's kind of in the middle there. It has a 2 hour delta for ruling out MI of less than 4 nanograms per liter. It has a 2 hour delta for ruling in of 10 nanograms per liter or more. One of my colleagues has a little saying, less than 4 out the door, 10 or more cardiology floor. So just try to develop your own little memory aids to try to help you remember the numbers so that you can use the assay in a sophisticated way. One of the things that you might notice about that table is that none of the values actually correspond to the 99th percent of normal reference range that the universal definition of myocardial infarction uses to characterize myocardial injury. And the reason for that is that as a binary positive or negative cutoff, the 99th percentile limit has really limited clinical utility for helping guide clinical decisions in the real world. Studies have consistently shown that even with high sensitivity troponin assays, you don't approach an acceptable accuracy for ruling out MI using a 99th percentile cutoff until you start seeing patients or start measuring it 6 hours or more after the onset of a patient's symptoms. So if you have a patient who presents 6 hours or more after their symptoms have started, and you want to use the 99th percentile upper reference limit of normal to rule out an MI, you're probably okay if they're 6 hours or more from the onset of their symptoms. But for most of the patients that you see, you're going to be far better off using a rapid diagnostic algorithm like I showed in the previous slides. On the other end of the spectrum, the specificity of the 99th percentile upper reference limit is also pretty lousy for ruling in MI. For most assays, the 99th percentile is somewhere in the low end of the orange range of those algorithms that I showed you before. So if you use it as a binary cutoff for ruling in MI, you're going to overcall MI in a lot of patients. And so for ruling in MI, you really do need to do serial troponin testing to look for an exponential rise in their troponin concentration. The 99th percentile limit is really just a minimum concentration that your troponin needs to rise above for you to consider MI as a diagnosis. But if you actually want to be sure, you need to use one of the diagnostic algorithms like we talked about. So you might wonder, should I use a 0-hour, 1-hour algorithm, a 2-hour algorithm, or a 3-hour algorithm? And I'm just going to come out and say, don't use 3-hour algorithms. They were developed early on in the high sensitivity troponin era. Most of them consist of 2 serial measurements 3 hours apart, looking for troponin concentrations above or below the 99th reference limit of normal. And they just don't have adequate accuracy for either ruling in or ruling out MI. If you use them, you're probably going to both overcall and miss MIs with most of the published 3-hour algorithms. So really the choice is whether you want to use a 1-hour serial testing algorithm or a 2-hour serial testing algorithm, and the deciding factor there comes down to how good is your lab equipment. So if you look at the 1-hour algorithms up here in the table, let's just take the one in the very top row, for example. The delta to rule out an MI with a 1-hour testing interval is less than 3 nanograms per liter, and the delta to rule in is 5 nanograms per liter or higher. So across 2 different troponin samples, the wiggle room that you have to differentiate between a patient who's ruled in and ruled out is 2 nanograms per liter. And that's not a lot of wiggle room. And so if you take the same assay, for example, and use a 2-hour algorithm, the rule-out delta is 4 nanograms per liter, and the rule-in delta is 10 nanograms per liter. So that difference between 10 and 4 is way different than the difference between 5 and 3. And so there's using a 2-hour algorithm for some of these assays, you're going to be much better off and at much lower risk of misclassification just because of assay imprecision. And a lot of clinical biochemists on the ground have said, look, these 1-hour algorithms perform really well in the literature, but they were done by research groups who ran the troponin samples. They did frozen plasma samples on all their patients. They ran them at once on a single analyzer in a batch using a single lot of reagent. So their variation is going to be very, very low. But just using my own hospital, for example, we run troponin assays 24/7 on 4 or 5 different analyzers, and we run through lots of reagent like it's water. So the variation in our assay in the real world is going to be much higher than what it was in the published literature. And so our clinical biochemists have said, yeah, the 1-hour algorithms look great on paper, but we just can't reproduce that degree of precision in the real world with our instruments. So for us, the best balance between speed and safety is to use a 2-hour algorithm. And so when you're thinking of implementing troponin testing at your hospital and trying to decide between whether you're going to use a 1-hour pathway or a 2-hour pathway, you have to have a really honest discussion with your clinical chemistry colleagues about whether the equipment can actually get you the degree of precision that you need to be able to safely use a 1-hour algorithm to be able to avoid misclassification. There's some other warnings that are important for us to talk about. Probably the biggest headache that we encounter are patients with chronic troponin elevations, and what do we do with them? Patients who have chronic kidney disease, patients who have chronic heart failure, they have troponin concentrations. They walk around with troponin concentrations that live in the observational or rule-in zone. And we just don't have a lot of evidence-based guidance around what to do with these patients. Really, all you have to go on is looking for a significant rise on serial testing or a significant departure from previous values measured using the exact same troponin assay. Another hard question is what to do with patients who have type 2 MI, so patients with arrhythmias or systemic illness who get bumps in their troponin because of demand and supply mismatch. We know that these patients have worse long-term outcomes. Most of the time, those worse long-term outcomes come just because they have worse systemic disease, and so they need more aggressive treatment. But a decent proportion of these patients are going to have undiagnosed obstructive coronary disease. And so it's a real conundrum what to do with these patients. There isn't any good evidence-based guidance. So I'm just going to give you my opinion that if a patient presents with a type 2 MI and they have symptoms of ischemia and they have ECG changes suggestive of ischemia, then they should probably be worked up for coronary disease during their hospitalization for whatever systemic illness brought them to your emergency department in the first place. On the other hand, if patients don't have symptoms and they don't have ECG changes and they're systemically well enough to be discharged home, so I'm thinking of patients who've had short runs of SVT, patients who've had symptomatic episodes of AFib who've either converted spontaneously or been cardioverted in the ED, if they have a small bump in their troponin, unless they had ischemic ECG changes and unless they had symptoms, they probably don't need extensive workups for suspected coronary disease. But if they do, their short-term risk is sufficiently low that those workups can probably happen as an outpatient. So if a patient is well enough for discharge, if they're asymptomatic, if their ECG is fine, if they didn't have symptoms of coronary disease in the first place, if they just had symptoms of palpitations with their AFib or SVT, they're probably good enough for discharge and workup for suspected coronary disease as an outpatient. One way that you can avoid potential headaches in interpreting troponin is consider whether the patient needs troponin testing in the first place. So think about a patient in their early 20s. They've had intermittent chest pain on and off for several days. It lasts seconds. They have a normal ECG. They have no risk factors for coronary disease. Their pretest probability of a type 1 MI is probably so low that there's no value in doing troponin testing for these patients. If you want to formalize that estimation of pretest probability, the HERE score has been evaluated in multiple studies. A meta-analysis of studies, including over 34,000 patients, estimated that the sensitivity of a HERE score less than 2 for ruling out MI was over 99% with tight confidence intervals. So not ordering troponins in patients with very low pretest probability is supported with very robust evidence. So in spite of challenges and growing pains, high sensitivity troponin testing should be a game changer in a positive way for the way that we do things. When we started using high sensitivity troponin testing in 2012, we were just terrified that now that we could measure and see detectable troponin concentrations in a lot of patients, this is going to lead to an unnecessary cardiology consultations and admissions. Across systems that have implemented high sensitivity troponin testing, though, the apocalypse hasn't happened. The proportion of patients admitted versus discharged has either gotten better or stayed the same. And there's been a meaningful decrease in length of stay amongst patients who've been ruled out. But it requires a few things to be successful. You need to get all of the people who are going to care about troponin results around the table and to agree on a common plan. On the emergency department side, it requires a commitment to adopt and adhere to an evidence-based algorithm. It means endorsement from clinical leadership and uptake across the whole department. On the cardiology side, you need commitment and specialty champions that say, yeah, I'm going to follow this pathway. A patient with a small but clinically significant delta change should be admitted for invasive or non-invasive testing, and we should have a plan to deal with patients with demand ischemia or type 2 MI. On the lab side, you need your colleagues to be able to be confident that they can actually have the precision with the equipment that you have on site. And on the informatics side, this is really key. that you need decision support that actually reflects the pathway that you're using. It's not enough for your EMR to report the 99th percentile reference limit and leave you to your own devices. You really need decision support that's actually going to reflect the pathway that you're going to be using in real life. So I'm going to turn things over to Dr. Singer, but I want to close by encouraging people to become sophisticated users of high sensitivity troponins. It's not a binary test like older generation tests. We need to abandon the terms negative and positive. And I want to encourage you to be sophisticated about the way that you interpret the whole range of measurable troponin values. And if you embrace the sophistication, you can make safer, faster decisions for your patients. Thanks very much.
Guys, do you have the mic on? No? No mic? Okay, now we got the mic. All right, so thank you very much for joining us today. How many of you have heard of an OMI, occlusion myocardial infarction? That's great. And so a lot of these talks that we get in emergency medicine about high sensitivity troponins focus on the patients who are ruling out. That's what we really want to do in emergency medicine, is be able to send home the patients who are unlikely to have an acute myocardial infarction, unlikely to have an adverse outcome. But we often don't talk as much about how do we make sure that we're ruling in the right patients. How many of you have sent patients with a STEMI to the cath lab and it turns out they don't have acute coronary occlusions? It's quite common. And how many of you have sent patients who actually have an acute coronary syndrome with EKGs that are normal or near normal, and it turns out that they do have a coronary occlusion? That happens too. So I think we kind of have to shift away of our discussion where we're only talking about identifying STEMIs. That paradigm doesn't seem to work anymore these days. This doesn't work? All right, so my disclosures, I do speak for AstraZeneca, and I do some advising for Abbott. And so really, what we need to decide when we see patients in the emergency department is who needs reperfusion and who doesn't. And if you look at the 2025 AHA guidelines for patients with acute coronary syndromes, all patients with suspected acute coronary syndrome need to get EKGs within 10 minutes and need to be reperfused within 90 minutes. And that's our focus, is finding out who needs reperfusion. But the problem is that really it's not the patients with STEMI who benefit, it's the patients who have an acute myocardial occlusion or coronary occlusion that benefit. And the reason why we use STEMIs to identify those patients is because many years ago there were studies that tried to find the association between EKG patterns and coronary artery angiograms, and they found that patients with STEMI had a higher rate of having an occlusion and were more likely to benefit than patients who did not. But it's really no longer acceptable because about 25 to 30% of patients who have an acute coronary occlusion will not have a STEMI. On the flip side, about 25% of patients who have a STEMI will not benefit from catheterization because they don't have an occlusion myocardial infarction. So we're really shifting the paradigm away from the STEMI paradigm to really focusing on how we identify these patients with acute myocardial occlusion. And we have high rates of false positives. For example, myocarditis, Takotsubo's, coronary vasospasm, spontaneous coronary artery dissections, and all of these patients are not going to be benefiting from that. So about 56% of individuals with acute coronary occlusions do not have STEMIs, okay? So we're missing a lot of patients. And as I mentioned, up to a third of the patients with STEMIs actually have an acute coronary occlusion, but they have an NSTEMI. So, and part of the problem with the STEMI paradigm is that we're actually using the STEMI both as the index text and the reference standard. So there's an incorporation bias, and you'd really never get any false negatives if you're using STEMI as your outcome. I'm sorry that I have to keep going back to this. So the whole paradigm started with Q-wave MIs and non-Q-wave MIs. And there are some in the audience, I'm sure, who are old as I am, who remember that that's how we classified myocardial infarctions. And it was around the year 2000 where they shifted from the Q-wave and non-Q-wave paradigm to the STEMI versus non-STEMI paradigm. And that was after they had studies looking at reperfusion of patients with chest pain and the benefits it had on reducing mortality in MACE. And they looked at over 60,000 patients in a meta-analysis. But in that meta-analysis, 4 of the 9 studies didn't even include EKG criteria, and 1/3 of the patients had no STEMIs. But they did find that the number needed to treat overall to reduce mortality was 56, which is pretty good considering other treatments. However, when they looked at the subset of STEMIs, it was 43, which was even better. So it seemed like STEMI was able to differentiate between those that were more likely to benefit than those that did not. Now, part of the problem with this whole EKG reliance for determining who's secluded and who needs to be reperfused is that an acute coronary occlusion is a dynamic process. It doesn't always manifest in EKG. The changes in the EKG are time sensitive, and they're very sensitive to reperfusion or reocclusion. It's also very important that the ST elevations are always proportional to the size of the QRS. So if you have a very small QRS complex, a very small ST elevation may be significant, even though it's below the 1 millimeter that we usually use. In addition, acute occlusion myocardial infarctions can produce other changes in the QRS and the T waves, or no changes at all. And it really depends on the timing of the recording of the EKG. There are areas of the myocardium that are silent EKG changes. It may be a very small area that's involved, and it may be low QRS voltage, all of which make it difficult to identify your classical ST elevations. And of course, there are many other causes of ST elevation. There's normal variants. There's abnormalities of depolarization like LVH. Remember that if you have an abnormality of depolarization, you're always going to have an abnormality of repolarization in the other directions. So people have recognized that there are other EKG changes that may indicate that that patient has a high likelihood of an acute coronary occlusion or an OMI. And people began to use STEMI equivalents or other types of terminology to describe those. And so thinking only of STEMIs really restricts our thinking. So really the question is not, is the patient having a STEMI? It's, is the patient having an OMI? And how do we identify that? So the question is, who benefits from an emergent reperfusion? It's those people who have complete or nearly complete occlusion of the coronary arteries. And why is it also so important to avoid acute coronary interventions in patients who have a STEMI who don't have occlusions? Well, it can cause coronary artery dissections, perforations. It causes early closure. So how many of you have seen a STEMI with chest pain, sent him to the cath lab, and it turns out they have an aortic dissection? That happens quite a bit, actually. It could cause arterial puncture. It could cause retroperitoneal hematomas. It can cause contrast-associated nephropathy, anaphylactoid reactions, large costs and resource mobilization. So there is a downside to bringing people to the cath lab. The other thing that's happened over the years, there's been a lot of argument about what an ST elevation is. How high is that? How many millimeters is that? Okay. The other thing is that in patients who have non-OMI ST elevation MIs, there's about a 1 to 2% risk of death from thrombolytics, and those patients have no chance of benefit. So for the past 25 years, there's been a lot of squabbling and argument about what should we use for a definition of an ST elevation. Is it a millimeter? Is it 2 millimeters? I just want to remind you what the changes are with classical acute coronary occlusions. And these are, of course, dynamic and very time sensitive. So initially, if we go to the top at the left, the first thing we get is a hyperacute T wave, which usually occurs within minutes to hours. We then get an ST elevation, which is followed by T wave inversion, and eventual recovery of the EKG, unless the patient has an aneurysm, a ventricular aneurysm, which often causes a persistent ST elevation. But what happens if there's reperfusion? And there could be partial reperfusion that occurs spontaneously. And that's where we get terminal T-wave inversion, which then later goes into a symmetrically deep T-wave. And this is the Winter or Widowmaker's EKG, which are patients who are at very high risk of having an occlusion of the LAD. So these patients also need to go to the cath lab, even though their EKG seems to be resolving. So what I'm proposing really, and this whole concept of OMI really was popularized by Stephen Smith, who was at Hennepin in Minneapolis, and Pendle Myers, who actually was at Stony Brook, and now he's at UNC. And basically, an acute MI, which is defined by clinical changes with the rise and fall of troponin, really should be divided into occlusion MIs, where there's a near total or total occlusion versus non-occlusion MIs. And those with an occlusion MI who have a STEMI are considered true positives. Those that don't have a STEMI but have an occlusion are false negatives. Those that don't have an occlusion but have a positive STEMI are called false positives, and those with negative EKGs that don't have a STEMI and don't have an occlusion would be called true negatives. And why is that important? Because even in patients with NSTEMI, about 1 out of 4 will have a total occlusion. And multiple studies with thousands of patients have shown that the risk of death, the risk of MACE, is considerably higher in patients who have an occlusion versus those that don't, even though it's an NSTEMI. Now, originally, in the first definition of an MI STEMI, which was many years ago, they defined an ST elevation as greater than or equal to 1 millimeter in most leads and greater than 0.2 millimeters in the V1, V2, V3. But then they did studies on different ages and different genders, and they found that there's a lot of variation in the J-point elevation based on age and gender. And then when the third universal definitions of MI came out, they actually changed it so that in all leads it was greater than or equal to 1 millimeter, but in leads V2 to V3, if it was a young male, it was 2.5 millimeters. If it was a male who was over 40, it was 2 millimeters. And if it was women, it was 1.5 millimeters. Okay, so there's been a lot of focus on exactly the definition of an ST elevation. But really, again, what we really care about is whether there is an occlusion or not. And here, we look at a Kaplan-Meier survival curves. The red are patients who have an occlusion MI, and the black is non-occlusion MI, and you can see a significant difference in mortality. Now, if you look at the distribution of the coronary arteries on the right side, we have the right coronary artery. About 80% of the patients will have a STEMI. The same is true for an LAD occlusion. But patients who have occlusions of the circumflex artery, less than half will have an ST elevation MI. So that depends on the coronary arteries. But what we've seen also that there are studies where early interventions, even in patients with NSTEMI who have occlusions, can significantly reduce the risk of death, MI, and PCI. You can see 2% versus 24%. Also, people began to see that there are other patterns of EKGs that identified high-risk patients who benefited from early catheterization and PCI. So on the right, they looked at patients with new ST depressions greater than 1 millimeter or T-wave inversions in more than 2 contiguous leads, and they were randomized to either immediate or delayed, which was like 61 hours on average, delayed catheterization. And again, you can see that the survival was much better with an immediate intervention. So what are those EKG patterns that we should be looking for that suggest that the patient might have an occlusion myocardial infarction? So this is the Wellens pattern that we talked about, the Widowmaker, where you have a biphasic T wave in V2, V3, which becomes also in an inverted T wave, that's what's called Welland pattern B. If you see that and the patient's having active chest pain, that usually suggests an LAD occlusion. That patient should go for an immediate catheterization, even though it doesn't meet criteria for STEMI. Hyperacute T waves, a broad-based, bulky, and disproportionately large T wave in any artery, again, suggests that this could be an occlusion myocardial infarction. What other patterns? There's the De Winter pattern, where you have an upward sloping ST depression and then a tall T wave that we see that suggests a proximal LAD occlusion when we see that in leads V2, V3. There's the Astlanger pattern. That one is any ST elevation in lead 3, ST depression in any of the V4 to V6 leads, or ST in V1 greater than in V2 suggests left circumflex or a right coronary artery in multivessel disease. And then there's the South African flag sign, which is a ST elevation in leads 1, AVL in V2, and an ST depression in lead 3. That suggests an occlusion in the first diagonal branch of the LAD. Other patterns that you should be concerned about are new onset bifascicular block, where you see a right bundle branch block and a left anterior fascicular block. That is associated with proximal LAD occlusions. Then there's the posterior OMIs, where you have ST depressions which are maximal in V1 through V4. Now, these actually have entered into the 25 guidelines of the AHA. So in addition to the traditional ST elevation patients that need to go to the cath lab, those that have a pattern that suggests a posterior myocardial infarction should also go to the cath lab. And then there's also the terminal QRS distortion that we see here that suggests an anterior MI when you see this in leads V2 and V3, and again is associated with an LAD. Other patterns, of course, we used to think that if patients had a left bundle branch block, we couldn't rule out an MI, but there are the modified Scarbosa criteria, which look at any concordant ST elevation greater than 1 millimeter, or discordant greater than 25% of the preceding S wave. Those also suggest that it is an acute occlusion myocardial infarction. There are other patterns here as well, the northern OMI and the precordial swirl. All of these patterns now suggest that there is an increased incidence of acute occlusion myocardial infarction. There's a study that we did. We looked at over 808 patients with ACS, and what we found is about half of them had an acute myocardial infarction, of which 33% were in OMI, and the other 16% were not. And basically, we found that the sensitivity, specificity, and accuracy of the STEMI criteria were less than using the OMI EKG criteria, some of which I had shown you, and that those were superior to the STEMI. Another study, well, how else can I tell if a patient comes in with chest pain, they don't have a classical STEMI, they may not have the typical changes that I've described. Another way of knowing whether they need to go to the cath lab is to do a POCUS. So how many of you do ultrasounds of the heart in patients with chest pain in the ED? So a patient like this, you're not sure whether or not to send them to the cath lab. You look for a regional wall motion abnormality. And what we saw in this study is that compared to the formal echo, the emergency physicians were very good at identifying regional wall motion abnormalities, and that in 87% of patients with regional wall motion abnormalities, we found an occlusion myocardial infarction. This is another study looking again at the role of POCUS to detect regional wall motion abnormalities, again showing that the EPs are able to identify this and that it has a high rate of sensitivity in identifying this. And what we know, of course, is that the location of the regional wall motion abnormality suggests which coronary artery is involved. So, for example, In the bottom right, we see a parasternal short, and the red, which is the anterior wall, that's associated with an LAD lesion, whereas the blue, which is more of the inferior wall, is associated with right coronary artery occlusions. So 2 quick cases. A man in his early 50s presents with substernal chest pain about an hour before, radiates to the jaw, he has diaphoresis, the cath lab was activated, and he received heparin and aspirin. Here's his EKG, and if you look closely, it really doesn't meet the STEMI criteria. There is some sinus tachycardia, there are S depressions in V2 and through V6 and in 1 in AVL, and possibly hyperacute T waves in V2. Okay? So this EKG would be diagnostic of an OMI. However, the cardiologist was immediately notified, came down, saw the EKG, and decided to cancel the cardiac catheterization. They repeated the EKG, and you can still see many of those changes that we talked about in the anteroseptal leads. You see the ST depressions. So this patient had a POCUS, and what you see here is a parasternal short, and you can see very good contraction of the inferior wall, but the anterior wall is not really moving. So this patient was taken to the cath lab because of this and had a 99% occlusion of the LAD. He had a thrombectomy. His peak troponin was 5. So here's an example of a patient who doesn't present with STEMI, who does have an occlusion myocardial infarction. And here's another one, another man in his 50s with epigastric burning for about 4 days, becoming worse today. He's got nausea and diaphoresis, and he has an EKG. So again, if you look at this EKG, it really doesn't meet the criteria for STEMI. There is some ST elevations in V2 through V4, but barely meet the STEMI criteria. But there are obvious reciprocal changes in ST depressions in 2, 3, and AVF. So we did a POCUS on this patient, and again, a parasternal short. You can see that there's contraction of this wall, but very little contraction of the anterior wall, which suggests that it's an LAD occlusion. And this patient went to the cath lab, and his first troponin actually returned elevated. And this is the cath before the intervention, where you can see an occlusion of the mid-LAD, which is 100%. And then after the intervention, you can see the coronary artery is completely visualized. So just to sum it up, we have always had what we call a code H, which is a STEMI patient. You call a code H, everyone comes in from the cath lab, the cardiology interventionist comes in, no problems. But because we've recognized that there are these other patients that also might have OMI and benefit, we've called what's called a heart alert. So when we call a heart alert, the EKG is faxed over to the interventionalist if they're at home. The cardiology fellow comes down, and basically what we do is we do a POCUS, and now that we're introducing high sensitivity cardiac troponin point of care, we're getting a point of care. So within 15 minutes, we know whether there's a regional wall motion abnormality, and certainly if the initial troponin is positive, that, of course, increases the likelihood that the patient has an OMI and should go to the cath lab. So that's how we see introducing the high sensitivity point of care test is in the patients who are high suspicion, but not enough to get the cath lab involved. And having that positive troponin might be the last thing that pushes the patient to the cath lab for the appropriate treatment. So thank you very much.
Thank you very much, Dr. Singer and Dr. McRae. I'd like to open the floor to questions. I don't know any of you who are also mid-career who feel like everything you ever learned is wrong. I feel like these talks are incredibly high yield. I've lived through 3 different troponin assays at my own hospital, and I feel like I need to go home and find out exactly what our cutoffs are and what our information technology is reporting to us. So this was incredibly high yield. Thank you both. I was interested, I'll open the questions myself. I was interested in if there is a sex difference in troponin cutoffs, and if that's something that we should be paying attention to in our clinical practice.
Sure, thanks. So there are sex-specific 99th percentile reference limits. There have been a number of studies looking at what happens when you implement high sensitivity or sex-specific 99th percentile reference limits, comparing them to universal reference limits. And what they found is that if you use sex-specific reference limits, you identify more cases of myocardial injury with women than you did using universal reference limits. But treatments didn't change and outcomes didn't change. And part of the reason for that is just systemic undertreatment of MIs in women. Women are less likely to get revascularized, less likely to get dual antiplatelets. But part of the reason for no change in treatment of outcome or our outcomes is that whether you use a universal 99th percentile or a sex-specific 99th percentile, the 99th percentile just isn't a good binary cutoff value for making clinical decisions. And so what we really need and what we don't have are sex-specific rule-in values, sex-specific rule-out values, and sex-specific delta values for each assay. So that's an ongoing evidence gap.
Interesting.
That would
Stay
better serve
tuned.
women.
It looks like there's some people lining up at the microphone. For those who are already coming in for the plenary, please join us. You may learn something very high yield like I just did in the last hour. So certainly go ahead.
Thank you. So I admit that somewhat sheepishly that a couple of those ECG patterns I wasn't familiar with, and I'll be Googling them a little bit here shortly. But with the Wellens, the patterns usually recognize when there's no chest pain. Are all the other ones that you mentioned generally when the patient's actually having chest pain?
Yes.
So if they're pain-free, those wouldn't
Well,
be...
it really depends, same with the Wellens. The patient may be pain-free, but may be having intermittent episodes of occlusion and opening and occlusion. So some of those patients will go to the cath lab even if they don't have chest pain, because there's just such a high association with high-grade stenosis and occlusion. Yes.
Great question. Thank you. Go ahead.
Hi. Thank you for the talk. You spoke a lot about the cath lab activation with the sign that looked like an OMI, but what about thrombolysis when you work in a rural center? So are these signs enough to take the decision to give the TNK, or?
I think you need to decide that with your cardiologist. We're lucky because we're a major center where we have interventional cardiologists available 24/7. But I would certainly bring up the conversation, review the literature with your cardiologist, and you have to make a decision together that if the patient does have continued chest pain and they have these patterns of the EKG, whether you're going to be giving thrombolytics or not. I would say probably yes, but especially if you're using echocardiogram at the bedside and you see regional wall abnormalities. But this would be a great place to have your point of care high sensitivity troponin. So you can get that, and that would be part of the decision making.
Okay, thank you.
You've asked a good question if other people sit down from the line because they had the same question. Go ahead, please.
For Dr. McRae, you mentioned ideally in the 01, 02, 03 that for most of us it's 02, and you said forget about the 03, but I think you had mentioned that there's some select cases where you want to get a 3-hour. Can you just go over that one?
I think what I mentioned is that if you're using a 0-1 hour pathway or 0-2 hour pathway, if they're non-diagnostic after the first 2 samples, then you would do a 3rd sample. And so that's going to be a couple of hours after the first one was done. So if you're using a 0-1 hour, then you would do a 3rd sample 2 hours after the first one. So it would be 0-1-3. If you're doing a 2 hours pathway and you need to do a 3rd sample, it would be 0-2-4.
Okay. And as a follow-up, in the nuanced, we're often told, oh, it's demand ischemia, it's a troponemia, forget about it, or it's rate-related ST changes. Again, not significant, but let's give a scenario. A 50-year-old comes in with an episode of SVT going at 150, 160, has some ST depression associated with it. We convert them whichever way we do. It normalizes some nondescript chest discomfort, no cardiac risk factors of note. Would you do a troponin?
If they had ischemic changes on their ECG, so if they were having ST depression while their rate was up in the 150s, I probably would, but that wouldn't necessarily prompt me to say this patient needs to be admitted for invasive investigations. Once their SVT is converted, they're out of danger. So what they probably have is some subclinical coronary disease. It's probably safe to be investigated as an outpatient, but having a pathway of what to do with these patients that you've developed with your own cardiologist is going to help you in the long term.
Yeah, that, very helpful. Thank you.
Yeah, I would just add that most patients with type 2 MIs, why do they have a discordance between demand and supply? Because they have underlying coronary artery disease. Yeah. So they should be investigated at some point, but it doesn't mean that now they're having your typical type 1 MI.
Thank you. So again, I'd like to thank Dr. McRae and Dr. Singer for their invaluable perspectives on this topic. I'd like to also thank the planning committee, the CAPE staff, and our IT staff for getting us started this afternoon. This session has been accredited by both the CFPC and the Royal College, so don't forget to fill out your evaluation forms and to claim your credits. We'll now move directly into the plenary. For those of you coming into the plenary, we'll just switch our speakers and then we'll get started right away. Thank you so much.